All right. Thank you all so much for joining. We're really excited to have you here today. I know people are still filling into the webinar. We'll give them some time to join, but we're going to go ahead and get started with some housekeeping items because we have a lot to cover today. So thank you so much. We're excited to have you. We have muted all lines during the presentation and except for the speakers. So if you have questions throughout the presentation, you can submit them during the webinar using the chat feature. And just because there are some coming through, oh, people are just saying hello. Okay. So you can, sounds like people know how to use the chat feature, but please feel free to use that to submit questions throughout the webinar. And if not, you can hold your questions until the end and I'll facilitate a Q&A session. If you think of questions after the webinar, please don't hesitate to reach out to us by email at atlas@shatterproof.org at any time. Again, that's atlas@shatterproof.org. If you are joining today with phone only, we want to alert you that our speakers will be using slides, so if you can view them, it will enhance your experience. Our speakers will be using video only during our introductions and our Q&A session to minimize the potential for challenges with home internet, which we all know we're experiencing these days, during the presentation. So you'll hear audio and see slides during the webinar. Finally, this presentation is going to be recorded and will be made available in the coming days. Again, thank you so much for joining us. Let's get started. My name is Sam Arsenal, and I'm the VP of National Treatment Quality Initiatives at Shatterproof. In this role, I oversee the development and implementation of Atlas, our quality measurement systems for addiction treatment facilities. I'm joined today by an esteemed panel of our colleagues at RTI International. Dr. Tammy Mark is an internationally known expert on behavioral healthcare financing, services, and quality measurement. She has authored more than 100 scholarly peer-reviewed journal articles and many government reports. Dr. Mark is an expert in the use of administrative data, such as insurance claims data for health and services and quality improvement research. She has consulted with SAMHSA, CMS, state Medicaid agencies, state behavioral health agencies, and behavioral health providers on the development and use of quality metrics. Hello, Dr. Mark. Next, we have Dr. Julie Seibert. Dr. Seibert has 20 years of behavioral healthcare experience, including program management, research, and direct consumer care. Dr. Seibert has extensive experience with quality management and quality improvement, including managing statewide quality strategies, developing performance measures, and developing monitoring tools and data collection processes. She has also held leadership roles in CMS and privately funded projects developing quality measures and public reporting systems for addiction and post-acute care. Hi, Dr. Seibert, great to see you. And finally, we have Sarah Zuckerbrand. Sarah has 25 years of experience in survey research in the healthcare setting. Ms. Zuckerbrand is the director of RTI's program and experience of care surveys and provides scientific and management leadership for the program portfolio of projects which design, implement, and manage surveys of patients, providers, and beneficiaries across multiple healthcare settings. Ms. Zuckerbrand focuses on surveys in the government's Consumer Assessment of Healthcare Provider Systems, CAPS program, and advises organizations and government agencies on modernizing patient surveys. She publishes and presents nationally about CAPS and patient experience. Sarah, it's great to have you. Okay, now I think our presenters are going to go off video just to try to prevent any issues with our bandwidth. For those of you who heard about this webinar through RTI's promotion or social media and are less familiar with either of our organizations, we'll start with a brief background. Shatterproof is a national nonprofit organization dedicated to reversing the addiction crisis in America. We were founded by our CEO, Gary Mendel, after losing his son Brian to the disease of addiction. Gary has since dedicated his life to ensuring others are spared the needless tragedy that he has experienced by creating Shatterproof and working to implement proven policy solutions, eliminate the stigma of the disease of addiction, and improve access to appropriate, high-quality, and life-saving addiction care. Today, we will focus on our work in transforming addiction treatment. As part of this, Shatterproof is working to standardize quality expectations through the National Principles of Care listed here. These principles, which we will review in more detail later in the presentation, were identified by a task force composed of subject matter experts, clinicians, and policymakers, and are based on research derived from the Surgeon General's landmark report in 2016. They are each shown to improve health outcomes across levels of care for addiction and across patient populations. Now, Dr. Seibert will provide an overview of RTI.
Thanks so much, Sam. This is Julie Seibert with RTI International, and RTI International has partnered with Shatterproof to develop Atlas, and we are so pleased to be able to present with Shatterproof today about this project. RTI is an independent nonprofit research institute that's dedicated to improving the human condition. Our role in this project has been to support quality measurement selection and specification, to provide survey design and data collection for the patient experience survey, to develop measure specification and provide data contributed technical assistance for the claims measures, to provide survey design and data collection for the treatment facility survey, and also to assist in website development. Back to you, Sam.
Thanks, Julie. For the duration of the presentation, you'll hear the speaker voices change as we discuss different areas of the project. We'll start with a description of the issue, provide an overview and sneak peek of our Atlas work, and then what you've all been waiting for, we'll dive into initial findings from Atlas Phase 1. Navigating the addiction treatment system is incredibly challenging. When people are in a time of crisis, they often face stigma and fear, in addition to systemic challenges like sorting through misinformation and high-priced marketing. Clearly identifying high-quality care is not only difficult, even for the experts on the call, given the lack of transparency in the space. Tragically, this causes many people to give up and not begin treatment, and others to begin treatment that is subpar or even fraudulent. It's time we make it easier to navigate to appropriate high-quality addiction treatment. That's why we've created Atlas. Unlike existing treatment locators, Atlas is not a pay-to-play system where addiction treatment facilities with high margins opt in. It's a comprehensive system that includes all addiction treatment facilities in the state on a level playing field. Atlas also focuses on the use of evidence-based best practices by facilities, not whether they have luxury services. As an organization that has far too much experience looking for addiction treatment, we've designed Atlas with the common questions and pitfalls that individuals with addiction or their loved ones might experience. And I have tested these concepts throughout the design and development with people who use drugs, individuals in treatment and recovery, and family members of people with addiction or who have lost a loved one. Atlas not only includes validated survey data, but also displays feedback from other patients, something we know from other healthcare systems is highly valuable in helping people make care decisions. In addition to the first transparent set of quality data for addiction treatment facilities, Atlas also includes the addiction treatment needs assessment to ensure people know what kind of treatment to look for based on their unique circumstances. And finally, Atlas is designed not just to assess facilities, but with the aim of improving the standard of addiction treatment nationally and supporting the adoption of best practices. To date, Atlas is a $5 million pilot program being implemented in 6 states: Delaware, Louisiana, Massachusetts, North Carolina, New York, and West Virginia. This pilot has been funded by Arnold Ventures and the Robert Wood Johnson Foundation, as well as a coalition of 7 health plan foundations, and is led by Shatterproof. The work would not be possible without our dedicated state agency and anchor organization partners in each of the 6 states. The scope has included identifying and testing quality measures, engaging stakeholders across each of the states to inform an iterative development and implementation process, gathering quality data, and building the website, treatmentatlas.org, which will launch next month. Atlas is designed with 4 user groups in mind. Of course, there is the public, individuals or families looking for addiction treatment. But shortly after the Atlas launch, there will also be password-protected professional portals for treatment providers, state agencies, and payers, such as health insurers and employers. The professional portals will be used to democratize Atlas data so it can be used to design and benchmark quality improvement initiatives, reform payment system to reward for quality over quantity, and enable the dissemination of resources and technical assistance in a targeted manner. As a sneak peek, when a person visits treatmentatlas.org, they'll see this homepage. As a first step, the Atlas user will be directed to take an assessment to see what kind of treatment to look for, or they can can conduct a search if they already know this. The Addiction Treatment Needs Assessment is a set of 13 consumer-friendly, expert-developed anonymous questions that rapidly assess the severity and risk of a person's addiction across each of the 6 ASAM dimensions, the industry standard assessment criteria. This resource was developed in collaboration with OpenBeds, a healthcare technology company, and the American Society of Addiction Medicine. Based on responses from the individual or the loved one completing the assessment, there will be guidance provided on the best treatment setting, for example, outpatient or residential, to look for as a starting point when looking for care, as well as other specific features like medications for opioid use disorder based on the patient's needs. Now, equipped with information on what kind of treatment to look for, the user can search on the Atlas database and use this information to filter results. Additional filters can be applied, such as insurance or distance. When Atlas users select a facility, they are taken to the facility profile, which includes contact and descriptive information at the top of the page. All addiction treatment facilities in the 6 pilot states will have a facility profile on the Atlas website. If they do not submit data, their profile will indicate data not available. Facility reported quality data are organized by the Shatterproof National Principles of Care that I mentioned at the beginning of the presentation in the Signs of High Quality Care section of each facility profile. Quality information within each principle of care can be expanded for more detailed information shown here with personalized evaluation and treatment plan. Below the signs of high quality care, patient feedback is displayed once a minimum of 20 responses has been submitted. This is the minimum threshold needed for reliability as determined in our testing of patient experience surveys. Patient feedback will continue to be gathered and updated every 24 hours, following the Atlas launch. More on this to come. But you may be thinking, how did we determine which measures to use in Atlas? Shatterproof ran a multi-step iterative process to identify the quality measures to use for Atlas. This involved several rounds of stakeholder and expert input and culminated in a National Quality Forum expert panel strategy session. The measures were designed to examine whether addiction treatment facilities are delivering care in accordance with the national principles of care. Originally, we anticipated using the scope from the SAMHSA database, but soon realized this would not encompass all of the state licensed facilities. As such, Shatterproof and our state agency partners engaged in a process to identify facilities that are in scope that is a combination of state licensing and SAMHSA facilities. We conducted a deep dive analysis between these lists to understand the discrepancies, but that's a topic for an entirely different webinar. Now, with the list of facilities identified, we'll move into the implementation of data collection.
Thank you, Sam. This is Julie Seibert again with RTI, and now RTI staff are going to provide you with information on our methods, including the data collection and the measure development using the 3 data sources in Atlas. As Sam's alluded to, there are 3 main data sources that contribute to Atlas, one being the Treatment Facility Survey, the second Patient Experience Survey, and the third claims data submitted by major payers in the 6 states. So in order to collect the Treatment Facility Survey and Patient Experience Survey data in the 6 states, we began with a list of over 2,600 facilities. And as Sam mentioned before, Shatterproof worked very diligently with various states and funders and state provider groups to develop comprehensive state list. Once RTI had the list, we emailed each facility point of contact and to explain project goals, the development of Atlas, and requesting participation in the Patient Experience Survey and the Treatment Facility Survey. Specifically for the Patient Experience Survey, we disseminated a patient-facing letter to each facility and asked each facility to distribute it to their patients. Patients were provided with a link to the patient survey and a pin specific to each facility. For the Treatment Facility Surveys, facilities were provided with a link to an online facility that also had a facility-specific pin. Shatterproof the Shatterproof state engagement was very extensive, and there were multiple efforts that staff engaged in, including webinars that were specific to states or that were provided across states. They also participated in in-person roundtables, in-person regional meetings, and also worked with various state partners and associations and business groups to develop letters that were emailed to provider participation to encourage their participation in Atlas. The next slide talks a bit about the treatment facility survey design. This survey was designed to gather information on clinical processes to shed light on quality of care. Some of the domains addressed by the survey include fast access to treatment, coordinated care for physical and mental health, and also access to medications for opioid or alcohol use disorder. We'll go a little more in depth about the various treatment domains later. As we'd mentioned before, the treatment facility is an online survey that's completed at the facility level, which was defined as physical location or address. The survey was designed to include multiple levels of care, including inpatient, residential, and outpatient care. Facilities that provide multiple levels of care were able to respond to the survey for each individual level or for all levels combined. Respondents reported that it took about between 30 minutes to 2.5 hours to complete, depending upon the array of services offered at the facility. Another data component that was collected through the survey that was related to quality were provider perceived barriers to delivering high quality care. These data included items regarding workforce barriers, administrative, and financial barriers. The next slide contains information about the treatment facility survey response rate. To back up a little bit, the data collection period for the treatment facility survey for 5 of the pilot states began October 14th, 2019, and it ended on January 31st, 2020. And the treatment facility survey for the state of Delaware ran throughout the month of January. During this time period across the 6 pilot states, we collected data from 1,276 facilities for an overall response rate of 52%. It's the final count. State response rates ranged from 74% in New York to 28% in North Carolina.
The second measure is the patient experience survey. It uses 7 domains which look at factors such as access to treatment, whether patients were offered access to behavioral health services, whether patients felt respected. Next slide, please. And involvement of family and friends. There are just 8 little questions on the patient experience survey. There is a measure of improvement in ability to function, and there is a narrative response on overall treatment experience. Here are the numbers of completed patient surveys from the 6 states in phase 1. As you see, 8,500 responses across facilities.
Thanks, Sarah. This is Tammy Mark. Again, the third data source are claims measures. 3 of the 4 claims measures were based on claims-based quality measures that had already been endorsed by the National Quality Forum. These included the percent of individuals with an opioid use disorder who are receiving opioid use disorder medications, the percent of individuals taking medications for an opioid use disorder who use those medications for at least 180 days of continuous treatment, and the percentage of individuals who were treated for a substance use disorder in a residential or inpatient setting who subsequently received follow-up treatment within 7 or 30 days of being discharged. These measures were originally designed to be reported for Medicaid programs and health plans as a whole. For Atlas, because we are trying to identify quality at the provider level, we re-specified the measures to apply to individual provider organizations. So for example, the first measure captures the percent of a provider's patients with an opioid use disorder who receive an opioid use disorder medication within 30 days of visiting that provider. In addition to these 3 measures, we also created a metric to capture what percentage of a provider's patients were admitted to the hospital or had an emergency department visit for an overdose or other substance use disorder related condition within 14, 30, 90, or 180 days of being treated by that addiction treatment provider. Because these measures have not been previously used in this way, they are available in a password protected professional portal, which can be viewed by providers, health plans, and Medicaid programs, but are not available to the public at this time. again, the goal here is to create a learning healthcare system by giving providers, Medicaid programs, health plans, and policymakers information that they can use to support continuous quality improvement. We tested the claims measures for reliability and validity using approaches that are typically employed when quality measures are being considered for National Quality Form endorsement. We found that the measures were reliable, which means that differences between providers cannot just be attributed to random noise. The measures were also determined to have face validity based on extensive feedback received from providers, policymakers, health plans, consumers, and other experts. We also tested the convergent validity of the measures. For example, we found that providers who had a greater percentage of their OUD patients receiving OUD medications, opioid use disorder medications, tended to have lower rates of substance use disorder-related hospitalizations and ED visits among their patients, suggesting that the measures also have convergent validity.
So I think now we're moving into our initial results, and I think Sarah Zuckerbraun will be.
Yes, the first principle we'll explore, and we're going to organize these by principles of care. And the first principle we will explore is fast access to treatment, which, as you see, is described on the slide. As we know, rapid access to appropriate care is critical. Using phase 1 data, we found that the proportion of facilities offering same-day access for outpatient services varied by state, with 87% of facilities in New York offering same-day access versus 60% of facilities in Massachusetts offering same-day access. And looking at inpatient and residential facilities, we explored which proportion offer additional assistance to patients if that facility is unable to offer immediate care. So again, across all Atlas Phase 1 states, most inpatient residential facilities reported referring patients to a specific facility in another organization. Fewer call another facility within the same organization. And the lowest proportion provide outpatient treatment until the appropriate level of care is available. When exploring fast access to treatment using patient feedback, 60% of patients overall reported always being able to see someone from the treatment program as soon as they wanted. And this was among all patients of all types of facilities, that is outpatient, inpatient, and residential. However, among facilities with at least 20 patient responses, a quarter of facilities had 50% or fewer of patients answer always, identifying room for improvement.
Okay, next we're going to explore the principle of personalized evaluation and treatment plan. As we know, no single treatment approach works for everyone. Personalized care is an effective means to treating chronic illnesses and has been shown to help individuals with addiction stay engaged, follow their treatment plan, and have better health results. So as a part of the treatment facility survey, Atlas asked whether facilities assess patients on the 6 ACM dimensions listed here. And they ask whether these patients are assessed at intake. These 6 dimensions were adopted by the American Society of Addiction Medication, and together they create a holistic biopsychosocial assessment that can be used to drive treatment planning across levels of care. The next slide shows the data we obtained from responses to the treatment facility survey, and we found that 81% of facilities across 6 phase 1 states assess patients on all 6 of the ACM dimensions. The next slide shows the most commonly assessed dimensions or the utilization of the 6 ACM dimensions of care across all facilities, and the most commonly assessed dimension is emotional, behavioral, or cognitive conditions and complications. 94% of facilities reported that they assessed that. The dimension that was least or most commonly excluded was readiness to change, and 87% of facilities reported that they assessed that at intake.
When appropriately prescribed and monitored, medications have been shown to save lives and sustain outcomes for individuals with substance use disorder. So these are another important dimension that Atlas assesses. Next slide. And Atlas does this through several different measures. We're just going to give you a flavor of some of that here. What we find in the pilot survey is that about 57% of facilities reported that they could prescribe naltrexone on site for treating alcohol use disorders. 59% reported being able to prescribe buprenorphine on site for opioid use disorder maintenance, and 17% dispensed methadone on site. Of course, methadone can only be dispensed in specially licensed opioid treatment programs, so the small percentage is not that surprising. Next slide. Atlas also shows information on medication usage based on claims data. The Medicaid claims measures show that among the average provider, about a third of patients with an opioid use disorder diagnosis filled a prescription for an opioid use disorder medication within 30 days of their first encounter with that provider. However, there was significant variation among providers, with that percentage being 13% or less in the bottom 10% of providers, and at 75% or more in the top 10% of providers. In terms of continuity of opioid use disorder medication, in the average facility, about a quarter of patients who filled an opioid use disorder medication used it for at least 180 days, with the range being 39% or more in the top 10% of facilities and 9% or less in the bottom 10% of facilities.
The next principle Atlas explores is effective therapies for addiction. As we know, proven behavioral health therapies have been shown to help individuals recognize and accept their substance use disorder, increasing their motivation to stick with treatment and sustain long-term recovery. 94% of facilities, that's shown on the next slide, offer at least one evidence-based behavioral therapy for SUD treatment. The most commonly used therapy is cognitive behavioral therapy, followed by motivational enhancement therapy, and mindfulness-based relapse prevention. Community reinforcement approach is the least common. Looking at patient feedback collected across all facilities, 75% of respondents reported that facility staff always show respect for what the patient has to say. Among facilities with 20 or more responses, in the top 10% of facilities, 97% or more patients answered that staff always show respect. However, the proportion of patients answering always ranged from 9% to 100%, so there's significant range in the quality of that domain there.
There's lots of research that has demonstrated that for addiction treatment to be effective, people must stay in treatment for long enough periods of time. For people to receive addiction treatment in inpatient or residential settings, this means it's critical that they transition to continuing treatment when they're discharged to outpatient settings. To examine this aspect of quality, we use claims data to calculate what % of an inpatient or residential organization's patients went on to receive outpatient treatment. Outpatient treatment was defined to include care delivered via telemedicine or involving a prescription for medication to treat addiction in addition to an outpatient visit. In the typical organization, about a quarter of patients received follow-up care within 7 days of discharge. This ranged from 39% or more in the top 10% of facilities to 9% or less in the bottom 10% of facilities. Again, the information here is meant to stimulate a learning healthcare system and quality improvement, and not to be critical or punitive. Next slide, please.
Okay, the next ATLAS principle we'll discuss is coordinated care for mental and physical health. And research has shown that people entering treatment for substance use disorder are typically also dealing with co-occurring mental health or physical health concerns. And the best way to improve overall health is to be treated for all concerns at the same time in a coordinated manner. This can also be essential for positive health outcomes and cost-effective care. The treatment facility survey included a question about the level of integration of mental health services. The question asked if services were provided on-site or off-site through an MOU or formal agreement or through referral. Across all states, we found that 68% of facilities reported offering mental health care on-site. This figure also includes telehealth services provided. Inpatient facilities were the most likely to offer mental health care on-site, followed by outpatient and then residential. We also asked facilities about the ability to provide psychiatric medications on site, and overall we found that 70% of facilities provide medications for psychiatric disorders on site. Inpatient facilities were more likely to provide medications for psychiatric disorders. As for integration of physical healthcare services, we found across all states 20% of facilities offer primary healthcare treatment on site. This also includes telemedicine, and 10% of facilities offer off-site primary care at a facility operated by the same organization or in the same delivery system or network. We also found that the slight majority of facilities, about 52%, referred individuals to external organizations for primary health care services.
So the seventh principle of care that ATLAS looks at is additional services to support recovery. Treatment is more successful if a person's living and job and relationships support treatment goals. Some treatment facilities may not be able to directly offer services to address these issues, but they should be able to help people find services to address them. So let's look and see what the data say about that. In the treatment facility survey, we found that 97% of facilities offer any form of recovery support. Selected forms of support are shown on screen. The most commonly provided recovery support service is assistance obtaining social services. 76% of facilities offer case management support. 57% offer peer recovery support, and 51% offer family services such as marriage counseling and parenting training. Of those services included in the survey, the least available was child care for patients' children. Across the phase 1 states, 81% of patients reported that staff at the facility talked with them about including family or friends in counseling or treatment. For facilities with more than 20 PES responses, the proportion of patients that selected yes ranged from 47 to 100%. So there's significant variation across facilities. Looking at some patient-reported data on survey data on outcomes, 80% of patients responding to the survey said treatment helped them a lot. 15% said somewhat, and 5% said a little. Looking at these same data at the facility level, among facilities with 20 or more patient survey responses, 10% of facilities had 100% of patients report they were helped a lot by treatment. The bottom 10% of facilities had 65% or less of patients say they were helped a lot.
Thank you so much, Tammy, Julie, and Sarah, for providing that information on the initial findings that we've seen in the ATLAS Phase 1 data collection. Again, as a reminder, this data will be available for people to sort through by facility when we launch ATLAS starting on July 21st. So it's a very exciting time for us, and we hope you can join us for the virtual launch event, which will feature special guests. Following the launch, we have identified these priorities. Shatterproof is working to sustain ATLAS in the original 6 states and expand to at least 10 states in 2021. If you or your state is interested, please connect with us. We will also focus on evolving and improving the quality measures in the future, but for now, we're very pleased and excited about the ATLAS launch next month. Thank you again for taking the time to join us. I've seen that the chat has been quite busy with questions coming in, and we're going to open it up to questions from the audience now. We can start by unmuting the lines and allowing people to ask questions, or we can read them from the chat.
Sam, I think this is Carolyn Davidson from Shatterproof. There are a few that came through the chat that I wasn't able to respond to that I'd like to pose to you and the panelists to start off with, if that's all right.
That would be great. Thanks, Carolyn.
Fantastic. So Mary Ward asks, what happens when the clinical diagnosis differs from the assessment taken online, referring to the addiction treatment needs assessment? How does that impact the provider?
That's a great question, and it's actually something that we do not track. So the assessment is an anonymous feature of ATLAS, so we don't track in accordance with the individual's patient journey or collect any patient-specific or personal health information in ATLAS.
Next, Amy Chin asks, for the patient experience survey in the analysis, I haven't seen a denominator or something to give us context on how many responses a facility or state would expect to get. Does the number, so for instance, how many patients does a facility see? Does the number of responses reflect 1% of patients or 100%?
Sarah, do you want to take this one, or would you like me to?
You can take it, Sam.
Sure. So we actually do not provide the information on the average number of patients that are seen at the facility, but we do provide the number of responses that are shown and included in the ATLAS data set. This is something that will actually continue to grow. While we have 8,600 responses to the patient experience survey at this point in time, that will continue to increase once we launch the site, because you can leave feedback in a crowdsourced fashion. So people can come onto the site and leave feedback in an ongoing way.
Our next question is from Benjamin Chin, who asks, was any consideration given to using a patient-reported outcomes measure instead of a patient experience survey, such as the NIH PROMIS measures, or alternatively, was there any consideration given to using patient activation measures?
That question may have come in before we went over the patient-reported outcome measure from ATLAS. Sarah, I don't know if you have anything else to add to that one.
Yeah, we wanted to be sure that we used measures that were well validated as survey measures that had been used in a survey setting, and therefore when we went looking for measures, we looked in things that had been used in a survey setting, such as CAPS Echo, CAPS Mental Health, clinician and group CAPS. Knowing that this would be done in a survey setting, you know, a PROM is usually done in a clinical setting. You know, you give the patient a questionnaire with a provider right there, or you give the patient a tablet to fill out, and we knew that that would not be the setting in which this was administered, so we didn't want to mix up a PROM that had been tested in one setting with a question given in another setting, and that is why we basically looked at measures that have been used in a survey setting only.
And this is Tammy Mark. If I could just build on your comments. Again, this is the pilot. This is phase 1. Most of the measures are, as you'll notice, are process and structure measures. In terms of moving forward with quality measurement, it would be an ideal to be able to get some sense of, as you say, outcome measures, patient-reported outcome measures. The systematic collection of reporting of that data. It's not at an advanced state in addiction treatment yet, but that would certainly be a good place, a good direction to start to move. Again, thinking about issues like risk adjustment and other factors. But thanks for raising that question.
Thank you both. A similar question posed by Glenn Field was, could you talk about the implicit bias in the question, how much have you been helped? You know, could this instead have been phrased, were you helped? And if so, how much? Regarding the patient experience survey.
Yeah, I saw this question come up on chat, and I'm trying to remember if this question came from Echo or if it came from somewhere else. All the questions that we used were tested and validated in large groups of respondents done in large surveys before us. And they tested well, and we used them with confidence. You know, it might say the word helped, you know, how much were you helped, but there are still options for not at all. And as you can see, people didn't hesitate to answer the questions. As you can see in the frequencies, which I could cite to you if you wanted, people didn't hesitate to answer the negative ends of that question. So I wouldn't think that there are a negative bias on that, but I'm falling back on the fact that it's a well-tested, a nationally well-tested and well-validated question. And I can look up the source, which is either CAPS, Echo, or the other one that I can't remember that we took widely from.
Hi, Sarah. This is Carolyn. I can confirm that it is from CAPS Echo. And I can repost. Carolyn. Sure. I'll repost the link in the chat for those who want to see more information about how the measures were developed. Next, we have a question from Glenn Field who asks, could you talk about the low response rates to the treatment facility survey in North Carolina and Louisiana?
Sure, I can take that one. This is Sam from Shatterproof. We have a number of ideas around the lower participation rates in the treatment facility survey by facilities in those states, as well as other states, you know, why certain providers would participate and others would not. One very clear reason is that in North Carolina, we announced the project much later in this process. So while other states were able to announce the project in February of 2019 and start to gather data in October, giving us many months to engage providers in the process, we announced in North Carolina in August, giving us only September and parts of August to engage before the survey went out into the field. So there was less time to engage providers, and there was also not a direct state agency partner in North Carolina that was involved. And, you know, they were a part of our state advisory committee, but did not have as much leverage in the project as we've seen in some of our other states. So that's one of our suspicions there. And I think there was also elements of, you know, some subsets of providers in those states that were not on board with the idea of providing data for these, for being transparently shown to the public in this way during the initial pilot phase, kind of wanted to wait and see how things played out before they would participate. And so we're very hopeful that moving into phase 2, that they will participate and that those numbers will go up not only in those states, but across all of the states.
Great. So that is all the questions that were sent to us via the chat, beyond those that I responded to directly in the chat. And so at this point, I'm going to allow participants to unmute themselves, as I believe we don't. Sam, could you confirm that we don't have the hand raise feature on?
Yeah, Carolyn, you can allow people to unmute themselves.
Okay, great. I will do so.
And we'll still take questions through the chat. If people are signing off, Thank you so much for joining us, and a big thank you again to our partners at RTI and our state partners and funders that have made this work possible. Again, July 21st will be the Atlas launch date, and we hope to see you virtually again at that time.
Good afternoon, it's Mary Ward. I just had a follow-up to the assessment question online. I appreciate your response, but I guess my concern is if people take the online assessment and basically self-diagnose when they arrive at a provider and their expectations are not met, are they going to have the ability to go back through Atlas and rate that experience?
Yeah, Mary, that's a great question. So that kind of goes to how the assessment was designed. It was designed in partnership with ASAM to align with the ASAM criteria. It's a derivative product of the ASAM continuum and co-triage, which have been validated to ensure that an assessment by a clinician aligns with the results from those tools. And so that is one element where, we would not be putting up anything on our site if we weren't certain that it's going to put patients in the right direction. In addition to that, we also have very clear language that indicates to patients that this is meant to be a starting point and guidance in looking for treatment, but that a clinical assessment will and should be administered by a clinician when they enter treatment that will ultimately provide the recommendation on their treatment plan. So both of those elements kind of in the development as well as the framing of the assessment tool and how it's being, how the results are being conveyed to the patient or the loved one include that they should expect to receive a clinical assessment to verify those results and ultimately inform their treatment plan, which is especially true in the case of people who are taking it on behalf of a loved one when often they may not know exactly the answer to some of the questions that we ask. And I see our numbers are going down, but we still have quite a few people on the line. So please don't hesitate to jump in if you have questions. We'll continue to hang on and see if there are others.
Hi, Sam. This is Colette Crows. I have a question.
Yeah, absolutely.
So could you say a little more about the role of states in the pilot and how you see that playing out going forward?
Sure. So during the pilot, the states have been involved. We have typically a state anchor organization or agency partner. It ranges from state to state. Sometimes it's the Medicaid office, the Department of Public Health, Behavioral Health, or the single state authority. And we work with those partners to identify the list of treatment facilities that will be included in Atlas. In many of the states, they actually were the ones calculating the claims-based measures that were involved in this, that we shared some of the results from. And they've also supported our engagement with the treatment community. So participating in our state advisory committees, which are multi-state collaboratives that include providers, payers, the state partners, and other champions and recovery advocates in the state, as well as helping to facilitate our provider roundtables and ensuring that Shatterproof staff can be available at any kind of moment or event that's occurring in the state so that we're well aligned with their priorities. Those state partners have been critical to the success of this initiative and in some cases have actually also required Atlas participation. For example, in West Virginia, it's a requirement that block grant providers complete the Atlas treatment facility survey as part of their block grant contract requirements. So the state partners will continue to play an integral role moving forward. We are looking forward to connecting with new state agencies and state partners and are in the process of briefing them now for participation in Atlas. We're also exploring state funding streams to support Atlas implementation moving forward, such as SOR grants and Medicaid contract requirements, as well as others.
Great. Just a follow-up, if I can. Have any
Of
of
course,
the
yeah.
states in the pilot expressed interest in collaborating with Shatterproof and figuring out how to actually use the results of Atlas to move the needle on quality?
Yes, definitely, and that's something that we're continuing to explore with them, and a great point, Colette, thank you for bringing that up. So now that we have this data, you know, what we presented today is really just a high-level snapshot of what we're seeing. There's a million different ways to slice and dice it, to go into state-specific information, to look at trends based on whether or not facilities accept Medicaid, or they are different levels of care. And so that's something that our state engagement staff is starting to work with, not only with our state partners directly, but also with those state advisory committees. In some cases, they've already started establishing work groups that include providers and the state partners to start to identify areas where they'd like to see more data visualizations or have specific questions that they'd like answered so that it can inform policy and advocacy work that we're poised to support on. And that said, I think that there's definitely existing technical assistance experts out there like yourself that we'd love to involve in this process to make sure that states aren't, you know, now that they're equipped with data, that they can best support quality improvement.
That's great. Thanks so much.
Absolutely. Thanks for joining.
We have a question from Jennifer Byrne in the chat who asks, has there been any consultation with existing addiction provider organizations such as NADAC on this project?
Thank you for that question, Jennifer. There's 5 national provider membership organizations that we've worked with on this project and that participated in the development of the quality measures. NADAC was not one of those groups. Additionally, in addition to those national organizations, we have worked with state-specific organizations within each of our 6 pilot states that span from addiction specialty organizations and societies to more broader hospital associations. Thank you for the question.
Hi, this is Mike Menkhouse. Can you tell me if there's going to be more? Can you tell me if there's going to be more webinars like this and when?
We certainly would love for there to be. If that's a request, then we can definitely make it happen. We will continue to put the word out about these kinds of webinars through our listserv related to Atlas. If you learned about this webinar via social media or via promotion from RTI International, then you can email atlas@shatterproof.org and we'll be sure to add you to our list. The next event will actually be our virtual launch event on July 21st at 11 a.m. Eastern Time. And then beyond that, I think the plan is to continue to do webinars like this with a more specific focus, like state-specific information.
Okay, thank you.
Absolutely. And I see a question in the chat from Gerald Morris about how we are going about selecting the next 10 states for inclusion. What is the best way to make sure our state, Michigan, is considered? This is a great question. We love to hear this. And we are talking with state leadership in many states right now. Obviously, this is a process that has been slowed down slightly due to coronavirus as state health agencies are in response mode as they are starting to emerge and, you know, think about other things other than the direct issue at hand with coronavirus. We're hoping to re-engage many of these state partners, and there's 2 areas that we need to consider before securing a state. The first is funding, and the second is agreement by state leadership to work on Atlas. And so we're happy to continue this conversation and understand from you if there's specific connections you can help us make in Michigan so that we could see if Atlas is a possibility, and we'd love to have those conversations. So please do reach out to us, both for this this specific incident or anyone else on the line who might be interested in learning more about how to get Atlas into your state. These have been fantastic questions. I just want to thank our speakers again, Tammy Mark, Julie Seibert, and Sarah Zuckerbrunn from RTI International, and for all of the participants for joining. If you have any questions and follow-up, again, I can't say it enough, please reach out to us. We're here. We'd love to talk to you at atlas@shatterproof.org, and stay tuned for the virtual launch event. I hope everyone has a great rest of your day, and thank you again for joining us.